Next slide. Okay, this is the WHO analgesic ladder. I think you already seen this picture yesterday's class. This is a stepwise approach to treat the pain, that is for both cancer and non-cancer pain. So here the stepwise approach is depending upon the severity of the pain. That is, in the step 1, it is mainly for mild pain, and the step 2, it is mainly for mild to moderate type of pain, and the step 3 is for severe pain. So it includes different types of medicines, that is depending upon the severity. In the step 1, it is included as a non-opioid medicine with or without an adjuvant medicine. If the pain is persisting or increasing, that is, or it is a mild to moderate type of intensity of pain, then it is an opioid for mild to moderate pain. That is, usually we are giving tramadol and tapentadol plus or minus non-opioid plus or minus adjuvant. If it is a severe type of pain, then it is an opioid for moderate to severe pain. That is morphine, methadone. So with or without non-opioid plus or minus adjuvants. So we will see our coming slides in detail about each medicines. Today we are more focusing on step 1 and step 2 drugs, plus what are the adjuvant drugs, and mainly small slides about the WHO analgesic ladder. Next. Okay, this is the W analgesic ladder. It is based on a recommendation of a group of international experts. That is, it is not for an opinion or the decision of a 1 or 2 persons. It is taken so opinion from so many peoples. They are international experts. They are coming to a conclusion that how the pain is controlled for both cancer and non-cancer pain. There is a criteria, so it is easily to manage all the health facility, all health professionals to treat the pain. So it is a stepwise approach. It came in action on 1986. So it was translated into 22 languages. So it caters for treating mainly for cancer pain worldwide. The main specific or the special thing for this ladder is it is a simple thing. So everybody can understand this ladder, and we can teach or we can give medicines. So it's a simple ladder, and it is very effective and well validated. So it is a worldwide used one, so it can be validated in everywhere. Next one is, it is, I already mentioned that it is a stepwise approach. So we have so many medicines for analgesics, but most of the time we are very much confused for what medicine we can give for this type of pain. There are different types of pain. I think yesterday's class, Dr. Ali was already mentioned what are the different types of, it's a nociceptive pain, neuropathic pain. There are different types of pain. So most of the time we are just confusing what type of medicine we can give to such a pain. So the severity of the pain also differs in each patient. Some patients we have only mild pain, some patients have moderate type of, some patient is very much suffering from severe pain. That is, they will tell it is a very severe, worst possible pain in their life. So depending upon the severity of the pain, we can give the medicines. So the WHO analgesic ladder is prescribing that, like it is depending on severity. So usually this step ladder approach will legitimize the use of opioids. Why? Because usually the before determining or before inventing this analgesic ladder, the most of the patients are dying with unnecessary pain. So most of the physicians also has a stigma associated with prescribing and taking opioids. So once the analgesic ladder came, it will legitimize the use of the opioids worldwide. Next. So in the WHO method, we can summarize summarized in a 5 phrases. That is, this is very important. everybody should learn this one. There is a 5 phrases for giving analgesics. That is by the mouth, by the clock, by the ladder, for the individual, and attention in detail. So these 5 phrases are very important. You should know what is the by the clock, what is by the mouth, what is by the ladder, for the individual, attention in detail. For our coming slides, we are studying what are the each thing in detail. This is the by mouth. By mouth means the oral route is the standard route, or it is the preferred route for all analgesics, preferably strong opioids. That is, it is usually very suitable for home cares, because usually we have some about beliefs that oral medicines are not working, IV or subcutaneous or IV injections are more useful for the acute pain. So, but we are mostly preferring oral route, which is very standard, and it is very useful for the home care services also. Next one, before in our palliative care, the home care visits are very common. So if the patient is bedbound, it's not walkable. If patient is not able to come to a hospital or any other clinic, so we prefer home visits and give medicines for the pain. So in that case, is oral route before because the morphine, this is the main strong opioid we are routinely using. That is also we are routinely giving as an oral route. Next one is by the ladder. By the ladder means I already mentioned that there is a WHO analgesic ladder. It is a stepwise approach. So we are starting from the step one according to the severity of the pain. Then move up. If one patient is came with complaints of pain, he says or she says, I have only mild pain, doctor. That is about 2 to 3/10. Then we will start as a step one. What are the medicines which included in step one? Anyone can tell? Step one medicines.
Please unmute and respond, or else you can post your response in the chat box.
Just tell me the group of medicines. I already mentioned that in step one, there is an, okay, tramadol, diclo, okay. Non-opioid medicines, okay, all are correct. Non-opioid with or without adjuvants. So if the patient is presenting with a mild pain, we will give the medicines included in the step one. The patient is presenting with mild to moderate, then we will give what it is a opioid for mild to moderate. That is a weak opioids. That is included tramadol. Next one. Next one is by the clock. By the clock means what? That is a continuous pain needs round the clock analgesics according to the duration of action of the drug. That is, if we are prescribing a medicine, usually we are giving medicines as 8th hourly, 12th hourly, 6th hourly. If we give morphine, it usually prescribed as 4th hourly. Why we are giving such a frequency of limitations for all medicines? Anyone tell what is the reason for we giving the medicines for in such a frequency, 6th hourly or 12th hourly? Yes, correct. Duration of action. Each medicine have its own duration of action. That's why we are giving as a 6th hourly or 8th hourly. In the case of morphine, we are giving as a 4th hourly because the duration of action of morphine is only for 4 hours in our body. So after the 4 hours, we are giving medicines. So if we are prescribing the medicine as 8th hourly or 6th hourly, but the patient is taking as a maybe SOS or OD dose, but it did not give any adequate pain relief for that patient. So we ensure that the patient is taking the medicine as prescribed as a doctor as a 6th hourly or 8th hourly. If we can give the medicine as an SOS or PRN basis, means it is only for the breakthrough pains. Next one is individualized to the patient. Individualized to the patient means what? If the that is depending upon different criteria. That is, if the patient, one patient is weighing 50 kg and the patient is weighing 100 kg, both the patient need same dose or different? Weight has any, body weight has any role? Different, that's correct. Because the most of the medicines we are prescribing as, that is this 15 mg per kg or 25 mg per kg. So depending upon the weight, body weight of the patients, the dose also changed. The next thing is, if some patient has some renal disease or some liver diseases, such patients also need some dose adjustments, because the most of the drugs are excreted through which organ? The medicines are excreted through which organ? Body excretion of medicines are kidney. Yes, good. Divya. That is kidney. So metabolism of the medicines usually taken in which organ? Metabolism of medicines. Liver, that's good. So in liver diseases or in renal diseases, we have to adjust the dose of the medicine. That's why we are individualized to the patients. The dry dose is one which relieves the pain. Titrate the dose till pain relief is achieved. Then next, the use of adjuvant drugs. That is, these are added at various steps for specific types of pain and to decrease the undesirable side effects of analgesia. The detailed about the adjuvant drugs we will come in the coming slides. So we will discuss in detail in that time. Next is attention in detail. That is patient age, body habits, comorbidities, drug interaction, side effect profile to the drug meticulously monitored. So these are the important thing which have giving we will give the medicines during what depending upon the WHO ladder. Okay, I think everyone should understand about the WHO ladder. This is the same thing I already mentioned, that is the oral route is preferred one, including morphine. For persistent pain, analgesics should be taken at regular interval, not as needed. So the main advantages are, it is simple, easy, effective, and it is universally accepted. And it can be used for cancer and non-cancer pain, and it is well suited for home care also. This is the main advantages of the WHO analgesic ladder. This is also, you already learned from yesterday's class, how we assess the pain. Because why should we, what is the importance of pain assessment? Because we have, if we have a thorough idea about the pain, then only we can give the medicines according to the ladder. So first we have to identify what is the type of pain, where it is occur, what is the radiation, any palliative or relieving factors, what is the quality of pain, what is the site, what is the severity, what is the pattern. Any queries? Okay, these are the important things. That is PQRST. It is the shortcut to remember what is the how we assess the pain. So the P is for palliating or relieving factors. That is what makes the pain worse or what makes pain better. Some patients tell what doctor, I have increasing pain after taking food or increasing the pain after walking. That is the what palliative, what aggravating factors. The relieving factors means patient takes have some massage or some oil massage or taking some medicines. These are the relieving factors. Quality means what would you describe the pain? What does it feel like? That is the patient tells what is the type of pain. Some patients tell it is a throbbing type, it is an aching type, what is burning type of pain, or it is an electric shock like pain. This is the intensity, this is the severe, that is what intensity or quality of pain. Depending upon the quality, the pain also differ. That is, yesterday you already learned nociceptive pains and neuropathic pain. So we can differentiate. That is depending upon the quality, we can differentiate. It is nociceptive or neuropathic. Next is radiation. That is pain is in one place, or it does it move to around your other parts of the body, or addict into the leg or something. So that is also very important to identify any radiation. Next is site and severity. Where is your pain? And the severity is depending upon the pain score. We have coming slides to understanding or identify what are the different types of pain score scales. Next is timing and treatment history. When did the pain start? How long the patient has this type of pain, and how often you get it? And what is the pattern? It is a continuous one, or it is an intermittent one. That is, everything is very, very important to managing for pain, because the each one has its own importance while we giving medicine. This is what is, I think you already know what is nociceptive pain and neuropathic. Nociceptive pain is a pain sensation resulting from injury of tissues. That is maybe a somatic or visceral. Somatic is usually what it has a sharp, aching, and throbbing type of pains. And neuropathic pain, it is resulting due to the nerve damage. It is mainly seen in diabetic neuropathy, chemotherapy condition. The patient says some electric shock like pain or kadapa, tharipa. In Malayalam, they say kadapa, tharipa type, peripa type of pain, or it is an burning sensation, burning type of pain. These are the main typical terms they are telling that it is like a neuropathic pain. So next we are assessing the severity of pain. While we are assessing the severity of pain, we have two criteria. That is, it is a unidimensional and multidimensional. We are more focusing on unidimensional. It can including verbal and non-verbal. So in verbal, it is a numerical rating scale. Numerical rating scale, just we are telling the patients that is usually 0 to 10. We describing the pain, and we ask the patient to what is the score of the pain, that is 0 to 10. Next is visual analog scale. The another one is categorical. Categorical means it is some patients not able to tell the score, that is 0 to 10 score, they are not able. So in that case, we are just asking patient, it is a mild pain or moderate pain or severe or very severe or excruciating. That's why we are categorize the severity of the pain. Next is non-verbal. In non-verbal, the main one is von Becker Faces scale. I will show the picture. Then next is FLAC. FLAC is mainly for children. That is, F is for F is mainly for face, L is for leg, A for arm, C for cry, and C for consolidability. That is, for the case of children, they are not able to tell the score. So this is the main chart for the children for FLAC. Next is Painart, that is for dementia patients, and for the elderly patients, we are using Dolo Plus. Okay, the first one is the von Becker's faces pain rating scale. That is depending upon the facial expressions, we are just rating the pain score. That is from 0 to 10. And the second one is numerical rating scale. That is, we tell the patient that 0 has no pain. From increasing 1 to 2, the pain will be increased, and the 10 is the worst possible pain. And the patient will tell what is the pain score. If the patient tells it is 2 by 10, it is a mild pain. That include which step of medicine we are giving. If the patient tells 2 by 10, it's a mild pain. Which step medicines we will give? Step 1, step 2, or step 3? Step 1. Very good. No, step 3. Step 3 is wrong. Step 1 is correct. Step 3 is severe pain. That is usually 8 to 10. That is the score of the pain for step 3. If patient is 4, 5, 6, that is moderate type. That is we give step 2 step ladder. Step 2 is the moves for 4 to 6 by 10 fourth way. Next. Okay, this is also the picture of the analgesic ladder. Here it mentioned that it is for the mild pain, the step 1, mild to moderate pain, step 2, moderate to severe pain is step 3. For the mild pain, non-opioid with or without adjuvant therapy. For step 2, weak opioid plus or with minus non-opioid plus or minus adjuvant. And for 3, it is a strong opioid with or without non-opioid and adjuvant. So in step 2, there is a what weak opioid plus step 1 we are giving, but we cannot combine step 2 and step 3. That is the main thing. You just keep in mind that we can give step 1 and step 2 together, but we cannot give step 2 and step 3 together. Weak opioids and strong opioids cannot be given together. This is the important thing. Then we are moving to drugs. This is step 1 drugs. Step 1 include for mainly for mild pain. It include NSAIDs and non-opioids means NSAIDs and paracetamol. So we can also we can combine with an adjuvant drug also. This is the step 1. Okay. We'll move to in detail about the NSAIDs. NSAIDs means non-steroidal anti-inflammatory drugs. These are the heterogeneous group of drugs which produce their analgesic effect through the inhibition of one or both of the isoenzymes of cyclooxygenase like COX-1 and COX-2. That is, this is a group of drugs which their analgesic effect is by the inhibition of two enzymes. That one is COX-1 and the another one is COX-2. This is the mechanism of action of non-steroidal anti-inflammatory drugs. So the important enzyme in the arachidonic acid cascade which produces tissue and the inflammatory prostaglandins. The next one. The prostaglandins mediates pain through the peripheral sensitization and amplifies the pain. So they sensitize the nerve endings and lower the threshold of the response to pain stimuli. This is how the NSAIDs act to give analgesics. So usually in nociceptive, pain is usually occur due to the tissue damage. So there is an inflammation is there. So these prostaglandins will mediate the pain through peripheral sensitization and amplifies the pain. So if we are giving this NSAIDs, this give anti-inflammatory effect, analgesic effects. Both action it will give by the inhibition of the enzymes COX-2 and COX-1. This is COX-1. COX-1 is usually present in all normal tissues like GI tract, platelets, kidney. These are the usual sites which are seen in COX-1. So it is a constitutive or housekeeping enzyme which mediates physiological responses. So this COX-1 is protects the stomach, kidney, and which facilitate the platelet aggregation. So usually this COX-1 is seen where it is in the GI tract, platelets, and kidney. So it has a protective effect to the stomach, kidney, and some platelet aggregation. But this NSAID's main thing is this has so many side effects. So while we using this NSAIDs, we will the use is very cautious because the renal toxicity and so many side effects are there. So we cannot give for a long time. Next is COX-2. It is an inducible enzyme. It usually occurs when there is an inflammation. So inflammation mediated enzyme is COX-2. So that is usually seen in lungs, brain, kidney, and testes. Their mechanism of action is by mediating the prostacyclin synthesis. So mediates the prostacyclin synthesis via vasodilatation and inhibition of the platelet aggregation. These are the main thing about the COX-2. So here we have two inhibitors. One is non-selective COX inhibitors and another one is selective COX inhibitors. The first we are discussing about the non-selective COX inhibitors. In the case of non-selective COX inhibitors means it will inhibit both the COX-1 and COX-2. That's why it is known as a non-selective. it has an action on both COX-1 and COX-2. Because of this action, it has depending upon the one action, it has some beneficial effects, and with the other, we have some adverse effects. So, what are the examples of non-selective COX inhibitors? One is ibuprofen, naproxen, aspirin, piroxicam, mefenamic acid, and ketorolac. These are the examples for non-selective. These are the things we are usually come across these medicines. That is brufen, naproxen, aspirin, piroxicam, mefenamic acid, ketorolac. We are routinely using these medicine. So these are coming under non-selective COX inhibitors. It has action. It will block COX-1 and COX-2. So how it acts, that is the mechanism of action. So by inhibiting the COX-1 derived prostanoids, that is the main adverse effects of non-selective NSAIDs, because it has GI side effects like bleeding, some hypersensitivity reactions, that is like angioedema, urticaria reactions, bronchospasm, and also renal side effects. These are the side effects which is action by the inhibition of COX-1. So it also has action to COX-2. That will result in what? That is the beneficial effects of this NSAIDs. That is what? It is an anti-inflammatory action, analgesic effect, and antipyretics. So non-selective NSAIDs has beneficial effects and also some adverse effects. The beneficial effects is acting by the inhibition of COX-2. That will result in what? It is an anti-inflammatory, analgesics, and antipyretics. But its side effects, the side effects is by the action of inhibition of the COX-1. That will result in GI side effects like bleeding, hypersensitivity, angioedema, urticaria, bronchospasm, and renal side effects. This is the main thing. This is the just I already mentioned that renal side effects, GI bleeding, ulcerations, hypersensitivity in respiratory, skin, and generalized. That is urticaria, bronchospasm. These are the hypersensitivity reactions. Next one is selective COX-2 inhibitors. What are the selective COX-2 inhibitors? Why it is known as selective COX? Because it has only action to COX-2. COX-2 enzymes, its inhibition action is only on COX-2. The examples are celecoxib, rofecoxib, valdecoxib, parecoxib, etoricoxib, lumaricoxib, and diclofenac. Here we usually seen routinely using etoricoxib, diclofenac, celecoxib. These medicines we are routinely using. Okay, that side effects compared with selective, non-selective, the selective has a little bit more. So while we using the selective in COX inhibitors, there is some risk factors to increase the GI toxicity. So if in case of any advanced stage or high and prolonged use of NSAIDs, history of some upper GI symptoms, concurrent use of aspirin, steroids, anticoagulants, in these cases, the risk factor for GI toxicity will increase. So while we using this selective COX inhibitors in these patients, we will little cautious, and we will maybe more the close monitoring should be needed. So there is a high chance for GI toxicity in these cases. Next one is renal toxicity. So if the patient has dehydration or if the patient is taking nephrotoxic drugs or some beta blockers like metoprolol in advanced age, the diabetes is poorly controlled. The patient is using AC inhibitors or diuretics. If the patient creatinine clearance is less than 30 ml per minute, this is also increase the risk for renal toxicity. So the most of the I already mentioned that most of the patients are excretion is via kidney. So if some patient has some kidney failure or some CKD patients or AK patients are there, these patients need we will have to find out the creatine clearance, and we will adjust the dose, because these patients need only small amount of medicines if when compared with the normal patients. Otherwise, if the patient's kidney is not functioning normal, the excretion of the medicine is not taking properly. So if we giving morphine, this duration of action is 4 hours. After the 4 hours, if the patient has normal kidneys, it will excreted. If the patient has some kidney diseases, the excretion is not taking place properly. So the medicine will accumulate in our body, and maybe if we take in the next dose, this will also increases uh, the amount of medicine in our body. This will result in toxicity and toxic symptoms the patient may appear. So if the patient with the CKD or kidney diseases, we will use the medicines within caution. Next is the below conditions which will increase the risk for stroke or myocardial infarctions. That is, the patients with advanced stage diabetes, hypertension, hyperlipidemia, smoking, and the use of COX-2 drugs. This will increase the risk for stroke or MI. MI means myocardial infarction. Okay. Are selective COX-2 inhibitors safe as compared to non-selective COX-2 inhibitors? This is the one question that selective COX-2 inhibitors are safe as compared to non-selective COX inhibitors, because it is safe for GIT as compared to non-selective. Why? Anyone tell why it is safe for GIT as compared to non-selective NSAIDs?
Kindly send your responses.
What are the non-selective NSAIDs? Tell some examples.
Please respond, otherwise we will not move further. Please respond.
Okay, Brufen. Okay, diclo, which group diclo coming under which group diclo? It is selective or non-selective? Okay, diclofenac is coming under selective. Diclo is coming under selective. These are the non-selective. Non-selective means brufen, naproxen, aspirin, piroxicam, mefenamic acid, and ketorolac. These are the non-selective. Okay, I already mentioned that in non-selective, it has some GA side effects, bleeding, hypersensitivity. This is seen in non-selective one, and in COX-2, we have these patients, the patient with GI toxic symptoms, or in renal failure, or in some patients have high risk for stroke and MA because of the protective effect to what liver, kidney. That's why it has some safe role. So in renal damage, it is comparable with non-selective NSAIDs. Selective COX is safe, and also prothrombotic. It is more likelihood of MI and stroke patients. So selective COX-2 inhibitors like rofecoxib was taken off from the market in 2004 because of his severe side effects. So we are routinely not using rofecoxib now because of the severe side effects, it was taken from the market. So while using this NSAIDs, we are just keep in mind that the lowest effective dose should be used for the shortest duration, which is required to control the symptoms. And the need for ongoing treatment, it should be reviewed regularly. It is very, very, very important, this line, because the most of the patients are they are taking too much NSAIDs from our nearby pharmacy or from some other areas. and they are taking for a long term. So this will cause severe renal damage or some cardiac issues. So many problems may have come. So if we are prescribing these analgesics or NSAIDs, it is for the lowest effective dose, should be used for the shortest duration to control our current symptom. And if we are planning to give for a long term, we should be reviewed regularly these patients. This is very, very important while we are giving NSAIDs. And while the other thing we have to keep in mind that if we administer NSAIDs, we will also give proton pump inhibitors, that is like Pantop, ranitidine, omeprazole. We should prescribe for the gastroprotection. And it is also cautious use in patients with peptic disease, advanced age, smokers, alcoholics, steroid taking patients, hypertensive patients, asthmatic patients, renal dysfunction, and in gout. These patients, we are very much cautious in use of NSAIDs. Next, we also avoid in bleeding tendencies or in with anticoagulation. If the patient has a peptic ulcer disease, if we are using NSAIDs, there is a high chance of bleeding and peptic ulcer perforation. So it is very important we are using in these patients with NSAIDs. And COX-2 selective inhibitors. So it should be contraindicated in atherosclerotic disease, CAD, which is coronary artery disease, and cerebrovascular disease. This is the main thing. We are not cautious use. This is contraindicated. It's not able to use in these conditions in atherosclerotic disease, CAD, that is coronary artery disease, and cerebrovascular accidents, that is stroke patients. We are not giving COX-2 selective inhibitors. Okay, next we are moving to paracetamol. This is we are routinely very much using in our routine life, that is paracetamol or acetaminophen. It has a predominant central action by inhibiting the enzyme cyclooxygenase in the CNS, central nervous system. The mechanism of action is by inhibiting the enzyme cyclooxygenase in the central nervous system. So it has no effect on the peripheral cyclooxygenase. So that's why it has a less side effects. So it has only action on central nervous system. It has a less action on peripheral. That's why it has a less side effects. What are the mechanism of action? That means it acting as an antipyretic and also analgesic action. So we are giving paracetamol for fever and also for pain. And it has a no anti-inflammatory action. That's why it is not coming under non-steroidal anti-inflammatory drugs. It has a no anti-inflammatory action. Then what are the dose? This slide is mainly tells about the dose. The safe dose is usually 12 to 20 milligram per kg Q6 hourly. That is the usual safe dose. That is 12 to 25 milligram per kg Q6 hourly. Daily dose usually not exceed more than 4 milligram. Single dose not, it should be less than 1 gram. And it is usually we already know that liver is paracetamol is mainly related with the hepatic toxicity, but yet it is safe in liver disease, but the dose should be less. That is, it is in liver failure patients, we can give as a 2 to 3 gram per day. In the normal cases, if the patient is normal, there is no liver disease, we can give up to 4 milligram per day. But if the patient has some liver disease, then we can give up to 2 to 3 gram per day. That is the usual dose. Next, the pediatric dose is 50 milligram per kg. And if oral route is not feasible, we can give as a rectal route, or we can give IV also. These are the first drugs. That is, what are the medicines which include in the first step? That is NSAIDs, paracetamols. These are the step 1 drugs. Next is adjuvants that we will see in the end of the slides. The second step drugs, that is usually weak opioids. That is mainly for what? It is mainly for mild to moderate pain. It includes codeine, tramadol, tapentadol, and dextropropoxyphene. These are the 4 medicines which are included in step 2 drugs. In each medicines we will discuss in detail. First one is tramadol. Tramadol is a centrally acting drug and it is known as a synthetic weak opioid. It is also known as weak opioid. So it is usually in the step we tell that it is the opioid for mild to moderate pain or weak opioid. That is a tramadol, and it has a dual mode of action. It will act on two receptors. One is mu opioid receptor agonist, and other thing is it blocks the presynaptic reuptake of serotonin and norepinephrine, and that will descending in the inhibitory pathways. These are the two mode of action of the tramadol. It will act on new opioid receptor agonist, and also it blocks the presynaptic reuptake of serotonin and norepinephrine. Next, it is usually the combination of tramadol and paracetamol is used as in step 2 drugs. We already discussed that. Step 1 and step 2 we can combine, but 2 and 3 we cannot combine. So we can give as a tramadol plus paracetamol in step 2. And one important thing is it has some neuropathic component. So it has some relief in neuropathic pain also. We will give the tramadol. It has some relief in neuropathic pain. Next thing is it has a high oral bioavailability is there, and the oral dose potency is 1/5 of the morphine. The oral dose potency compared with the morphine is 1/5, and the IV dose is 1/10. It is very important. So you just keep in mind that oral is 1/5 of the morphine, and the IV is 1/10 of the morphine. That is the equivalent dose when compared with the tramadol and morphine. If we are giving 400 milligram of tramadol, that will be equivalent to 40 to 80 milligram of morphine. That is the comparison. And 50 to 100 mg, usual dose is 50 to 100 mg every 4 to 6 hours. Usually we are prescribing 50 or 100 mg Q6 hourly. That is the usual dose. And the maximum daily dose is 400 milligram. Not more than 400 per day. Maximum daily dose is 400 milligram. Next drug is tapentadol. It is similar to tramadol only. But this also have a dual mode of action. That is, one is mu receptor agonist and also inhibitory pain pathways, and to prevent the reuptake of serotonin and norepinephrine. And this tablet is available as the strength, that is tramadol, that is 50 and 100, and usual the dose is 50 to 150 mg 6 hourly up to 400 milligram per day. That is the tapentadol. The next one is codeine. Codeine is 1/10 potent as morphine. The main metabolite of the codeine is codeine 6-glucuronic CYP2D6. That is, it is the main metabolite of the codeine, and it is a prodrug of morphine also. The onset of action of the codeine is 30 to 60 minutes, and the duration of action is 4 to 6 hours. So we can give as a Q4 hourly or Q6 hourly. It is mainly using for pain relief, cough suppressant, and anti-diarrheal, and it is also we are not routinely using now. This is the adverse effects of these weak opioids, that is tramadol. Usually, if we are giving tramadol if we are giving tramadol as first time, we should inform the patient that there is a chance of nausea and vomiting. It is very important. So before giving the tramadol, we just give it antiemetics like metoclopramide or ondansetron. We are giving just prior to the medicine as a TDS dose for 3 days. After that, the patient advised to take as an SOS dose, that is antiemetics. And dizziness and drowsiness, that is also very important. If we are prescribing tramadol to patients, most of the patients telling that they are feeling dizzy, drowsiness. So you have to be careful about that also. And some patients have hallucinations and confusions. And the another important thing while we are giving tramadol, that is there is a chance to seizure. That is, the patient has a history of seizure. This medicine will decrease the seizure threshold. So the patient has get reoccurrence, or again there is an episode of seizure may occur. So if the patient has an history of seizure or the patient has any chances to get seizure in future, we are just cautious in using tramadol. That is the step 2 drugs. We are already discussed step 1 and step 2. In both steps, we are just mentioned the one term, that is adjuvants. What are adjuvants? How these adjuvants give analgesic effect for pain management. So adjuvants means adjuvant analgesics means that's any drug which has no primary indication for pain, but it has some effect on the pain relief. That is, it will help to pain relief or it will facilitate the analgesic effect. That is the adjuvant analgesics. Usually, we are telling that if one medicine, it has not we are using routinely or mainly using for pain. It has some other actions, but it has some action for pain, or it helps to facilitate some analgesic effect. That's why we are using as an adjuvant analgesics. And we just seeing what are the examples of adjuvant analgesics. Because we are using antidepressants, anticonvulsants, corticosteroids, bisphosphonates, cannabinoids, ketamines, anesthetics, and neuroleptics. These are the medicines or drugs which are using as an adjuvant analgesics. These medicines have primary action is different, but it has some action on analgesia. That's why it is known as adjuvant analgesics. This is very important. Okay, first one is multi-purpose adjuvant analgesics. That is, first one is TCA. What is TCA? What is TCA? Anyone tell what is TCA? Yes, good. Tricyclic antidepressants. Okay. Tricyclic antidepressants. They are amitriptyline, imipramine, nortriptyline. These are the tricyclic antidepressants. The next one is alpha-2 agonists like clonidine, corticosteroids like dexamethasone, prednisolone. These are the multi-purpose adjuvant analgesics. Okay. Usually, we are coming across the neuropathic pain. I already mentioned that some electric shock, like burning type of pain, that is the some, this pain is due to the nerve damage. So in these cases, we are usually giving, our first line management is with antidepressants. So we are routinely using first one is TCA, that is tricyclic antidepressants. One is amitriptyline. And the second one is SNRI, that is duloxetine. And another one is anticonvulsants, that is gabapentin, pregabalin, carbamazepine, sodium valproate. And the third one is corticosteroids. These are the first line medicines for first line medicine for neuropathic pain. Why we are giving antidepressants for neuropathic pain means the mechanism is not clearly known, but it has some action or some action on pain relief. So we are routinely using that in an antidepressants in a lower dose. For if we are giving amitriptyline for an antidepressants, it given at higher doses. But for pain relief, we are using as a lower dose. Usually, we are giving amitriptyline as 12.5 mg HS at a starting dose. If patient has no adequate pain relief, we will increase the dose as 25 mg, 37.5. That is depending upon the pain severity and pain control. Next one is duloxetine. That is also for the pain relief, we are giving as a 20 milligram HS. Next one is anticonvulsants. That is gabapentin, pregabalin, carbamazepine, and sodium valproate. In these cases also, the epilepsy and the pain, they both are sharing the same physiology. That is neuron hyperexcitability. Now, what is epilepsy? Epilepsy also some abnormal activities in the brain. So there is a neuronal hyperexcitability. In same case, we have also pain. So this anticonvulsants also has some analgesic effects. That's why we are giving gabapentin and pregabalin. That is also in a very low dose for the pain relief. Usually gabapentin we are giving 100 mg or 300. In pregabalin we are giving as a 75 milligram as an HS. Sodium valproate is 200 milligram. That is, usually we are starting at a very lower dose, and depending upon the pain control, we are increasing the pain medicines. Next one is steroids. Steroids also plays a major role to getting pain relief. And what are the contraindications for giving TCA, the tricyclic antidepressants? The first one is severe cardiac conduction defects, and arrhythmias, heart failure, severe BPS, and narrow angle glaucoma. In these cases, we are not using tricyclic antidepressants because the amitriptyline, they will also cause some urinary hesitancy, some dryness of mouth. So in BPH also, we are not giving. And some arrhythmias, severe cardiac issues, we are not routinely using TCAs. Next, some other neuropathic pain relieving agents are, one is oral and parenteral sodium channel blockers. Another one is NMDA blockers, that is ketamine, amantadine, and third one is baclofen. These also have used as a neuropathic pain relievers as an adjuvant. Next adjuvant is topical analgesics. That is, one is local anesthetic like lignocaine. So usually we are giving lignocaine for local anesthetic, but we also give it as for analgesics as an IV. IV lignocaine usually 3 to 5 milligram over 4 to 5 hours we are giving for pain relief. Next one is NSAIDs, that is mainly local and topical NSAIDs, that is diclofenac gel, that is mainly for acute musculoskeletal conditions. This local NSAIDs, the systemic what absorption is very less. So we can give for some prolonged period. It will do not harm the renal, not too much. So we can give for a local topical NSAIDs for long time, not for too much, but we have to monitor the patient. Next is capsaicin, that is also a topical analgesic. Next is for bone pain. Usually, if the patient has some CA, carcinoma, patient will present with some skeletal metastasis. The patient has severe bone pain. In that cases, we will consider bisphosphonates, radiation, steroids, and also calcitonin. This is also relieve the bone pain. Other one is bowel obstruction. Bowel obstruction is we usually give steroids. The role of the steroids in this adjuvant is to decrease the peritumoral edema. That will also decrease the pain. So we are routinely giving steroids for bowel obstruction, and also octreotide. Octreotide is a somatostatin analog. It will decrease the secretions and also decrease the that bowel obstruction. And the another thing is anticholinergics, that is hyoscine butyl bromide and glycopyrrolate. Hyoscine butyl bromide means buscopan. We are routinely giving for complete obstruction cases. And if the patient is presenting, the patient is in the end of life period, there is increased secretion and death rattles may be seen. In that cases, we are routinely giving glycopyrrolate to decrease the secretions. These are the adjuvant drugs. This is little bit about corticosteroids. The corticosteroids means it is mainly for neuropathic pain we are giving, and mainly for bone pain. And if the patient has some headache from headache due to some raised ICP, that is ICP means intracranial pressure. So in that cases, we are giving corticosteroids to decrease the that's brain edema. That will decrease the pain and also the symptoms which may be due to the increased ICP. And arthralgia, that cases also it has some anti-inflammatory actions and edema decreasing actions. So we will routinely give steroids. And in bowel obstruction also same mechanism of action, and the pain from spinal metastasis. We are routinely giving steroids like dexamethasone. It is a single dose we are giving. Its half-life is 36 to 54 hours. So yeah, why we are giving dexamethasone means it has a less mineralocorticoid side effects. And we are routinely giving dexamethasone as a single dose during the morning time, because if we are giving in the excess or in the evening dose, it may cause insomnia. So that's why it is very important. We are giving the steroids in the morning time at a single dose. And we also giving along with the PPIs, proton pump inhibitors, along with the dexamethasone. Okay, I think everyone should understand what is WHO analgesic ladder, what are the drugs which included in the step 1 and step 2. The step 1 and step 2 is included in the pain management part 1. And step 3, that is opioids, strong opioids, are coming to management of pain part 2. Thank you all. Anyone have any?
Thank you, Dr. Susan, for the wonderful presentation. Anybody have any doubts? Anybody? I hope your presentation is clear to everyone. They all are understand well. So about today's presentation, so I would like to highlight one or 2 points. Other all points she has mentioned very well and thoroughly explained. So the NSAID, which we are using in the step WHO analgesics ladder, step 1, step 2, step 3. Anywhere you want, you can use NSAID, right? So when we give NSAID, there are some side effects. Madam has mentioned about that. So I am planning to highlight again because the doctor will be prescribing NSAID, but we are the persons to educate the patient and family, the caregiver about to how to take tablet and what are the precautions they have taken. These all things very important because one NSAID can cause acute renal failure. That you have to keep it in mind all the time. So you have to tell them to take plenty of oral fluids so that all toxic effect will excrete out through kidney. Okay, so that we can able to prevent that side effect. And also they always take NSAID after food. So because one of the main the side effect of NSAID is gastritis. So they should they should make their stomach cause that really because they need to take some food. Definitely they should take food and also they should take some that proton pump inhibitors. So that is very important. These 3 things you have to educate them, and also when they come for a follow-up, you have to ask them whether there is any side effect of these. So if there is any, there are another side effects also. These are the most common side effects. So you have to ask them if you if they have mentioned anything, you have to just to tell the concerned doctor so that they will add some drugs. So we need to protect their stomach also. So that is very important. Okay, so all other points Madam has mentioned very well, and also adjuvant and adjuvants. Adjuvants is also you have to understand very well. Adjuvant is a drug, is not primary. The particular drug, the primary action is not an analgesic, but it can be helpful in some painful conditions. So tricyclic antidepressant, there are many drugs. So you have to, so the main purpose of that medication is not an analgesic, but it can be helpful in some painful condition. That is adjuvant analgesic. Okay, so always you have to think about the 2 different types of pain, nociceptive pain and neuropathic pain. Most of the medications which we are using for systemic that analgesics, like morphine. So sometimes that if that patient is having neuropathic pain also, the morphine will not help much. So that time you have to add some tricyclic antidepressants or that anti-epileptics or corticosteroids, these kind of adjuvants. So that you have to keep it in mind. Always when we do the assessment, you have to do the thorough assessment. Then only we can able to understand the type of pain. If you understand the type of pain, then you can manage well. So the assessment is very, very important. Okay, thank you. If they don't have any questions, we can move on to the case presentation. Miss Shreya will be presenting a patient story today. Miss Shreya, over to you.
Shreya, please unmute yourself and you can start the presentation.
Yes, ma'am. Good afternoon, ma'am. My name is Shreya Mage. I am CHO from CHC Kurcharam, Goa. My patient's name is Bibijan Budyar, female. Her diagnosis is left buccal mucosa. She is having complaints of pain while having food and talking and sleeping on one side. A history of illness. A history of oral cancer, a left buccal mucosa that is being spread through the left breast, and it was operated 1.5 years back. Examination. On examination, patient has marks of sutures on the left side of the cheek, which follows the left side of the chest as cancer has spread to her chest. According to PQRST assessment, pain is present. Pain while having food and while talking, that those are precipitating factors. And quality, patient has pricking and burning pain. Radiation, pain radiates to the left side of the chest. Sight and sensitivity, on pain scale, the pain is from 1 to 2. And timing and treatment history, pain started after the operation and patient is on treatment for pain. Patient always verbalizes of burning sensation as she had taken chemotherapy. Treatment and significant investigations. Cancer was operated 1.5 years back. Patient has taken chemotherapy and radiation therapy, and now the patient is taking tablet Narvigen and tab pregabalin 75 mg orally. Psychological aspects. Patient has a feeling of guilt because of cancer. As also, she is feeling depressed. Family history. There is no one history of cancer in their family and no other significant history also. Medication, present medications are tab pregabalin and tab Narvigen, and also patient is hypertensive and she is taking tablet amlodipine. Main concern is only about pain. She always complains about pain every time whenever she comes to the center. Patient was having a history of chewing tobacco, which caused her cancer, and later the cancer was operated and she went under chemotherapy and radiation therapy. The discussion points are how to manage her burning sensation and pain in the chest. And pain is mild but persistent. She always complains about the pain in the cheek area and also in her neck area. Thank you.
Thank you, Shreya, for the excellent presentation. Anybody have any doubts or any clarification needed? Please ask her. Otherwise, we can move on to the discussion points. So I would like to know about the family history. Who's the primary caregiver? Is there any other family members? So I would like to know about that. And also, I would like to know about that medication, Narvigen. What is that? What is the pharmacological content of that medication? Ma'am, over to you. So we would like to hear from you all. This is the patient. Is having neuropathic pain and usually while moving and while taking anything through mouth, so the patient is having pain. So this patient is on pregabalin, and the another medication is Nervigen. So the question is about how to manage the chest pain and intermittent pain, so that radiating pain, that all things. So we need to discuss among us. Please put your answers, your suggestions in the chat box.
Okay, I want a clarification about one history also. Here, the examination part mentioned that there is a marks of sutures on the left side of the cheek, which follows the left side of the chest also. In the history also, she also there is a history of oral cancer, left buccal mucosa spread to left breast. Is it spreading, or it is some graft taking from that area? I just
No,
find
ma'am, graph was not taken, ma'am. Actually, it had spread, ma'am, that time.
spread to breast.
Yeah. Yes, yes, ma'am.
Okay. What is the content of that Nervigen?
Actually, ma'am, that is also pregabalin methylcobalamin, ma'am.
Okay, combination of medicine.
Yes, yes, ma'am.
Okay. Did you think what type of pain he's suffering from? It is a nociceptive pain or neuropathic pain? Anyone can tell. Not Shreya. She is complaining of pricking and burning type of pain. The pain is where is the site of pain?
Site of pain, ma'am, cheek area, neck area, and the left side of the breast, ma'am.
Okay. From there, the pain is radiating to the
Until the chest area.
radiation to the left side of the chest.
Yes, ma'am.
Okay. Any wound or anything is there? Any ulcer?
No, ma'am, no any wound, nothing is there, ma'am. Just she always complains about pain.
Okay. The pain score is 1 to 2.
Yes, ma'am.
Okay. Patient before taking this pregabalin, his pain what is the pain score?
Since the time of operation, ma'am, that time only they have given her that treatment, ma'am. So before that we don't know, because after operations, after many days we got her as a palliative patient.
Okay. Now after taking the pregabalin, she has a 1 to 2 by 10 of pain score.
Yeah, ma'am. Yeah.
Okay. Any relieving factor is only the medicine, no other thing.
Only
food?
medicines, ma'am. Nothing else. Nothing.
He's taking medicines. Taking food orally or IELTS to feed?
Orally, ma'am. Nothing is there.
Okay.
Who is the primary caregiver?
Actually,
Is
she
there any
only
family?
works, ma'am. She and her son. Nobody else. She also works.
Okay, she also works.
Yeah.
Okay.
That is why she had a habit of having tobacco, ma'am.
Okay, nowadays, what is the condition? So now also she is able to work, or not able
Yeah,
to
ma'am.
work?
That she can walk. She can do other activities. Just sometimes she complains about, means every time she comes to the center, she will complain about pain, and she'll always ask for any medication or diclofenac and all.
Okay. So, what do you think? Why she is telling about pain? So
Ma'am,
we
actually,
have to do the yeah.
ma'am,
Yeah.
actually because of operation, ma'am, that she must be having that pain, and also she had went through that radiation and chemotherapy. No, ma'am. So that pain will be there for her, and she's dependent on medication, so she feels like she has to take.
I lost you in between, sorry.
Okay.
So yeah, so the primary, she is working. She is under the pain. Her pain control is adequate with the pregabalin, right?
Yes, yes, ma'am.
Okay.
Hmm.
So okay. No other family issues, no psychosocial issues, everything,
No,
right?
ma'am. No, any psychosocial issues because she also talks with everyone. She travels. She walks on her own. She'll go to market. Everything she does.
What about sleep?
She sleeps, ma'am, but that also some 1 to 2 times she complains us regarding that while sleeping also she'll get that burning pain and sometimes the sleep is disturbed.
Okay. So okay. So the pregabalin HS or what is the dose?
75 mg, ma'am. Pregabalin.
75 mg
Yeah,
HS.
yeah, ma'am.
OD morning or after HS dose?
HS.
Only one time,
Only
right?
one time.
Okay. So I think no more suggestion. Maybe we can add some non-pharmacological things. We can tell some non-pharmacological measures. Otherwise, this medication, if the patient is not getting adequate pain relief with this medication, then we can continue with this. I think so. What about Susan, ma'am? What do you think?
I think we have to explore more because any other reasons for any other psychological or any other reason for pain. I think if the patient has a pain score of 1 to 2 by 10, it has an adequate control with the pregabalin. Otherwise, the patient has severe pain, some more than 5 or something. So we will explore more some what any other psychological issues because there is a total pain that is very important for pain management in our palliative care. So we are just giving the medicines for only for physical pain. So if we explore more, we have to find any other reasons for pain. So we will find out that and we will find a solution for that. Then she will get uh, more pain relief.
Yes, ma'am. That's true. So I think if they don't have any questions, we can wind up. One chat. Yeah, so Dechen is telling altered body image for the patient. So definitely, if there is any altered body image there, definitely this will be affecting the patient emotionally. But at the same time, she is working. So there is no social isolation or family isolation there. So I think if these kind of things there, definitely we have to explore it. So is there any emotion? Is there any problem facing from others? These kind of things we can explore. If there is some kind of problems there, definitely we can give a psychological support to her. Need special attention. Here also we need to look into the total pain aspects. We have to understand the physical aspects, social aspects, emotional aspects, and spiritual aspects. So always when we do the assessment, you have to assess the four aspects. So if you assess the four aspects, yesterday I told you about the total pain concept. If there is any psychosocial issues there, their physical intensity, the physical pain intensity will increase. Okay. For example, if the patient is having 6 out of 10 pain score there. So if there is any psychosocial issues are there, so there are that psychosocial issues are the contributing factor. Because of that, the pain score will be the patients will be saying like 8 out of 10, 10 out of 10, that kind of things. So if you explore the psychosocial issues, or if you can able to listen that that problems, and we can support, or we can give a another solutions, or we can give a psychological support. So that kind of thing you have to keep it in mind. Okay, thank you.
Thank you, ma'am.
Okay, we can wind up.
I thank all of you for being attentive. I want to thank Susan ma'am for such an elaborate and informative session. I'm sure that all of you are well aware of the topic now. It will benefit you in your professional life. I thank you for all being active participants of the session. See you on the next session. Goodbye.